All right. Welcome, everyone. We'll get started. It's exactly 2 o'clock now. So this is the DDW Combined Clinical Symposium, Multidisciplinary Management of Malignant GI and Biliary Obstruction. We're thrilled to be your moderators today. Dr. Krishnan is not here, but he did send in a video, and we're going to play that video, and we can include any sort of commentary in the discussion that follows as well. This here, right?
And to the moderators of this session.
All right, you're hired.
It's a privilege to talk about endoscopic approaches to access the biliary tree in malignant biliary obstruction. I only regret that I'm not able to give this talk in person for all of you in San Diego right now. Here are my disclosures. This is an outline of what I'll be speaking about today. First and foremost, I'll go over some of the tools and tips we have for performing ERCP. For many, ERCP is still the tried and true gold standard for managing malignant biliary obstruction. We'll go over malignant hilar obstruction, which has its own set of nuances and challenges. I'm going to be spending a lot of time going through EUS-guided options for biliary access. This is an evolving and growing technology for managing complex biliary obstruction. And lastly, I'll be talking about combining these technologies together to manage our patients. So it goes without saying that ERCP is the standard of care for managing malignant distal biliary obstruction. This study by the group at Michigan published this study in 2021 using SEER database looking at survival in patients who underwent ERCP versus percutaneous drainage. And they noticed that survival was improved in patients who underwent ERCP compared to those who underwent percutaneous drainage or no drainage at all. And of course, there are some confounders in this study, but needless to say, I think that it doesn't take much to convince people that for malignant distal biliary obstruction, ERCP with stenting is the standard of care. This is what our standard ERCP looks like in patients with pancreatic cancer. We can use a standard sphincterotome, papillotome. We gain selective biliary access, advance our guide wire, and perform a cholangiogram to confirm the size and location of that stricture. Though not always necessary, a biliary sphincterotomy is performed. Once the sphincterotomy is performed, we can advance our stent, and oftentimes that will be a metallic biliary stent. Now, what type of metal stent should we be using in the context of malignant biliary obstruction? I think there's been a little bit of controversy in terms of using covered versus uncovered metal stents. We know that compared to plastic stents, these stents have much more durability, and certainly in those patients who are getting neoadjuvant treatment, a metal stent is better. There's been initially some concern about using covered metal stents for the risk of cholecystitis. And so this was a systematic review that looked at some of these issues. So this study noted that the rates of acute cholecystitis were actually not statistically significantly different between the two groups. However, tissue ingrowth was increased with the uncovered metal stent, while migration was increased with the covered metal stent, likely related to the use of neoadjuvant treatment, tumor shrinkage, and subsequent improvement in the stricture. In addition, they looked at cumulative survival rates. They were unchanged, not surprisingly, between the two groups. This is another study, this time done by the group at Mayo Clinic, comparing uncovered and fully covered metal stents. And what they noticed is that clinical success was comparable between the two groups. However, adverse event rates were actually higher in the uncovered metal stent group, largely related to the fact that these patients had an increased risk of stent occlusion and need for unplanned reinterventions. They also note that the time to patency was considerably better with the covered metal stents. So both of these studies essentially showing that from a clinical success standpoint, certainly longitudinal, fully covered metal stents may have a benefit. And the rates of cholecystitis appear to be similar for both groups. So certainly ERCP seems to be pretty straightforward for patients with malignant obstruction, but there certainly are challenges to standard ERCP, and there are reasons why standard biliary cannulation fails. One of which is anatomic. So this is a picture showing various anatomical variants of the ampulla. And you can see that if you have an ampulla like type A, shown in A or B, these are pretty straightforward cannulations. However, the others, they're large intraduodenal segments, S-shaped curves to the common channel, all factors that can make selective biliary cannulation difficult, if not impossible. So what do we do in these situations? This study was a prospective study on how to assess difficult cannulation. And in this study, about 63% of patients had success with standard cannulation, and they used some of these salvage techniques for challenging cases. What are the salvage techniques? These are what we would call advanced DRCP maneuvers, including pre-cut needle knife, papillotomy, transpancreatic papillotomy, double guide wire. And with those techniques alone, we can increase that success rate from the 60s to closer to the 90s. All right, so what happens if you've employed those techniques and you still can't get into the bile duct? Well, we have two options. We have the tried and true percutaneous biliary drain, which is still certainly not a bad option. But I'm going to talk about some of the EUS guided techniques that we have to access the bile duct. First is the EUS guided rendezvous, and some of you have seen this. This patient had pancreatic cancer and had a very distorted duodenum. So we're pulling the folds, trying to actually find the ampulla, which is retracted and caught within a stricture around D2. And you can see here that we are unable to get access. In this circumstance, I switch to EUS, and you can see a dilated extrahepatic bile duct. I typically like to stick at the left hepatic, but in this situation, we found a good spot with the extrahepatic bile duct. We then advance a guide wire anterograde across the ampulla, and you can see here, this is where the wire is coming out. We grasp that wire using our standard duodenoscope, pull it in through the channel, and then once we do that, we have stable access to the bile duct. Once we have access through the papilla, we can complete our sphincterotomy and ultimately advance our metallic biliary stent. So a very good rescue mechanism in cases where we can access the papilla, but we can't really get. It's a study that was published in the Annals of Internal Medicine, a prospective randomized controlled trial, looking at the rendezvous technique compared to some of these advanced ERCP maneuvers in gaining biliary access. And essentially what they showed is that both techniques are highly reliable at gaining biliary access. Adverse events in expert hands can be quite low. The rate of post-ERCP pancreatitis is acceptable. The time to procedure can be slightly longer using the rendezvous. So the question becomes, well, if we can stick the bile duct and access it with a guide wire, why do we have to do a retrograde ERCP? And so in this spirit, the idea of EUS anterograde stenting was developed. This basically uses the same principles of rendezvous that I described by sticking the left hepatic duct or the common bile duct and advancing a guide wire anterograde. And then using that same wire without switching scopes, dilate the tract and place a stent anterograde, as can be seen right here. This was studied by a retrospective review of 54 patients who had failed ERCP. These were both palliative and neoadjuvant patients. And 47 out of 54 had successful anterograde stent placement. And moreover, 11 of those patients underwent successful surgery without any unintended complications. Now, it's important to note that these are very high volume centers with international expertise in EUS biliary drainage. So it's not something that I would say that somebody with standard EUS skills would be able to do. These are very high volume centers, but nevertheless, it is a possible treatment option and in some ways can certainly streamline the process. This has further led to the idea of doing a direct EUS-guided biliary drainage called a EUS choledochoduodenostomy. Here's a case that I had several years ago of a patient with a ampullary cancer that completely obliterated the opening of the biliary orifice. You can see that just by gently probing the periampullary area, there's bleeding. We then try to access parts of the bile duct, and we just keep entering into these false tracts that form. So, switching to EUS, we can easily see a markedly dilated bile duct here, just adjacent to the duodenum. Um, and using a cautery enhanced lumen opposing metal stent, we can advance that catheter directly into the bile duct and deploy our lumen opposing metal stent. So I can say the ERCP portion was over 30 minutes, maybe even close to 40 minutes, whereas the successful EUS guided biliary drainage, this was about 3 minutes. And so certainly a very, very streamlined process if you have appropriate and favorable anatomy to drain the bile duct. So when we look at a case like this, many of us who do both EUS and ERCP started to think, well, that was a lot easier, a lot more streamlined. It took 5 minutes. We have successful biliary drainage. Do we really even need ERCP anymore? And to that end, the group in Orlando, led by Ji Bang, did this very nice randomized controlled trial comparing EUS guided choledochoduodenostomy to ERCP for primary biliary decompression. Now, remember, these weren't patients who had failed ERCP. This was a intention to drain the bile duct with either EUS or ERCP. And you can see in their studies, the adverse event rate was similar between the two groups. Technical success was similar between the two groups. Interestingly, procedure time was actually quite similar, though I think with the use of a lumen opposing stent, this procedure time would have decreased significantly. Treatment success at 2 and 4 weeks, comparable, and moreover, surgical resection was able to be performed equally within both groups. Since then, there have been two additional randomized controlled trials. This was published in Gastro, comparing the use of a lumen opposing metal stent for EUS guided choledochoduodenostomy to ERCP, the Element trial. Now, these are in patients with locally advanced or unresectable pancreatic cancer. And you can see that in the intention to treat analysis, clinical success was comparable in both groups. Stent dysfunction was also comparable. Stent patency was numerically less in the choledochoduodenostomy group, but this didn't reach statistical significance. And also mortality and the rate of a Whipple procedure was similar. In that same edition, the group from Hong Kong published a similar randomized controlled trial. And the one caveat being that this was not done necessarily with lumen opposing metal stents. They note that technical success was actually higher in the choledochoduodenostomy group, largely, I think, owing to the fact that duodenal obstruction was able to be dealt with. Procedural time, 10 minutes compared to 25, so less procedural time. Adverse event rates were similar, reintervention rates were similar, and readmissions were also similar. So some pretty robust data saying that, well, do we even need to expose these patients to ERCP when we have an alternative? And I think that in the context of a multidisciplinary discussion, as this session is, the question for my surgical colleagues is, what do you guys think about this? Is this something that would make you kind of cringe at the idea, especially in a neoadjuvant patient, or do you guys feel comfortable with this approach? And this was, at least in some ways, partially answered by the Dutch pancreatitis group. The Dutch pancreatic cancer group, when they retrospectively looked at their pancreatic cancer patients who underwent choledochoduodenostomy versus ERCP. And they compared some of the outcomes of these two groups, and they noticed that The time to surgery was similar amongst the time to surgery was slightly less in the choledochoduodenostomy group. However, other factors were roughly similar in regards to surgical resection, with the exception of operative time, for whatever reason, was slightly less in the choledochoduodenostomy group. In regard to postoperative outcomes, more or less similar between the two groups. Complication rates were the same, fistula rates were the same, infection rates were the same. There was a trend to lower major complications in the choledochoduodenostomy group. This didn't really reach statistical significance. But then they provided a survey for those surgeons who performed the Whipple procedure in patients who had a choledochoduodenostomy. It's important to note that about 3/4 didn't even see the stent during the resection. And then when they asked them, was the surgery complicated by the stent, about 70+% said it wasn't really an issue for them. However, in two cases, they felt that it severely complicated the surgery. In all cases, there was plenty of space between the hilum and the stent. And then in 90% of cases, they didn't have to change the surgical plan. So, not a large amount of patients, only 29, but you could look at this in one of two ways. You could either say that, well, there's a reasonable amount of data that this should be our first approach. There are some benefits. But you can also look at it and say, well, two of the patients, 2 out of 30, had a severely complicated Whipple procedure as a result of the choledochoduodenostomy. So certainly, you get one shot at it. This is an oncological catastrophe if that were to happen. So I think it requires more data and more collaborative discussions amongst the gastroenterologists, surgeons, and the oncologists. In 2025, how do we approach malignant distal biliary obstruction? Well, this was a systematic review and meta-analysis comparing EUS biliary drainage to ERCP. And as you can see, there are a variety of parameters that are comparable, both technical success, clinical success, stent patency. In terms of complications, you can see that overall adverse events rates are seemingly lower, though not statistically significant. However, pancreatitis, understandably, is considerably less prevalent in EUS drainage. So we know that both are relatively comparable. Traditional ERCP is probably the gold standard, though many experienced endosonographers and interventional endoscopists have noted that teaching EUS biliary drainage, because of the direct visual aspect, is seemingly easier than teaching traditional ERCP, which has a lot of tactile feedback, a lot of subtle nuance that can be more challenging to teach and train. So for these malignant distal biliary obstructions, standard ERCP is successful in about 80% of cases. If you're able to add enhanced maneuvers to your toolkit, that'll kick it up to about 90-95%. Rendezvous can salvage about 5 to 7% of cases if you have access to the ampulla. Different ballgame if the ampulla is either obscured or it's obstructed. There's growing data, though, on choledochoduodenostomy as an alternative. It seems to have less complications, no risk of pancreatitis. You don't need to access the ampulla. It's quicker. You're going to do an EUS to get a diagnosis anyway, so you don't even have to change out the scope. However, I do want to mention that there's a reason why the surgeons have abandoned choledochoduodenostomy for many, many patients. It's not a good long-term strategy in patients without cancer or with very indolent cancers. The risk of reocclusion is going to be considerably high. So this certainly involves a multidisciplinary discussion for each individual case. So EUS hepatogastrostomy is another technique that has been used to access the bile duct in malignancy. We often access through segment 2 and 3. Mainly able to achieve left-sided drainage, though unlike choledochoduodenostomy, it is an intraperitoneal stent delivery, and there are many technical nuances. In Asia, there have been some dedicated stents that have been developed for hepatogastrostomy to minimize the risk of complication. However, those are not available in the United States. Dr. Kadkoti and Irani have published very recently a very nice review on tips and techniques for EUS-guided hepatogastrostomy. And I can say that the main nuance involves the initial stick. You can see that getting into that B2, B3 radical from the esophagus sometimes is your best option. However, you don't want to go transpleural in this situation. Certainly a challenge when you have a large hiatal hernia. The angle of your echo endoscope can also make a big factor in whether or not you can advance your guide wire anterograde, and can also play into whether or not you can advance your tools beyond that. So again, unlike the choledochoduodenostomy that I showed you earlier, where there's a large dilated bile duct adjacent to a very thin-walled duodenum, it's a different ballgame with hepaticogastrostomy. We have a fibrotic bile duct wall, a large amount of liver parenchyma, intraperitoneal space, and a very thick gastric wall. So while sticking the bile duct may be possible and plausible, the next step of advancing tools and devices across this area can be quite tricky, and there can be enormous resistance. This has been mitigated to some degree by the development of small caliber cystotomes, but even with that, getting the adequate force to push forth across all these layers into the bile duct is the largest challenge. And I think without dedicated tools, this is still going to be kind of reserved for very, very unique cases. There are going to be mishaps. This was a paper that was published. Sorry. This was published just in GIE about a month ago. This was a patient who had a hepaticogastrostomy and the stent had migrated, which has been reported many times because of respiratory variation, the stomach going up and down. You can get displacement, and you can see here laparoscopic rescue of the stent. This biflange stent is not available in the United States, but it is one of those dedicated hepaticogastrostomy stents. And you can see how, with the surgical technique, they're sort of plastering the stomach near the liver to prevent further migration. So things that the group should be aware of. So hilar biliary obstruction is, I think, also a slightly different. There's a slightly different take when we look at endoscopic approaches. I won't go through the debate on metal versus plastic stents or percutaneous drainage versus ERCP, but I think it's fair to say that in 2025 we've shifted away from draining two sides to draining as much healthy liver parenchyma as possible. There's growing data that if we can drain greater than 85% of liver volume, this can result in better outcomes, certainly in those patients who are awaiting liver transplant, or even in those patients who are just receiving chemotherapy. And so it has been somewhat of a challenge to be able to access all of these segments. And so I wanted to run through some of the tips and tricks that we have for this process. This is a patient with a bismuth type 2 obstruction who came in with jaundice and fever, and you can see there was a previous stent just on the right side. And then using our angled and torqueable glide wires, we're able to advance into these areas. Once we're able to get into the left hepatic duct, you can see that it's markedly dilated. We subsequently dilate the stricture and can place stents across this area. This is really doable only with the use and development of these hydrophilic angled guide wires. And I oftentimes will take the wire and try to feather it across the strictures. It's sort of a mandate and a requirement to have high quality imaging because, as you know, we shouldn't be over-opacifying segments of the bile duct that contain tumor, and certainly segments of the bile duct that we can't drain. So almost you have to go in with a mental map of where you think your obstructed segments are, and then you can feather the guide wire, ideally with high quality fluoroscopy, to get to where you need to go. This is true not only of our bismuth 1 strictures, but our bismuth 4 strictures. These are patients who have come in either awaiting transplant, and with high quality MRCP, we do have to drain all of that healthy parenchyma. They frequently come back with cholangitis if we don't. And so we can oftentimes get many stents into these areas, but it can be arduous and taxing, but it certainly is rewarding, certainly when we get them to transplant. In the last few minutes, I wanted to put this all together and sort of highlight, I think, a very instructive case that shows the overall armamentarium of tools that we have to access the bile duct in patients with cancer. This was a very unfortunate 25-year-old who I took care of with cholangiocarcinoma, who underwent a resection with Roux-en-Y hepatocogaginostomy. Unfortunately, had a very early recurrence within 5 months, had bilateral PTBD placed, and then unfortunately also presented with a gastric outlet obstruction. And she really wanted to be without the percutaneous drainage. So first, obviously, I know this is not the point of this talk, but we had to deal with the gastric outlet obstruction. So we did a endoscopic ultrasound guided gastrojejunectomy. But with the hepatocogaginostomy, we had a challenge of being able to access multiple ducts. Certainly not doable with that duodenal obstruction, and with the use of our single balloon or double balloon enteroscopes, we just wouldn't have the tools to access those areas. So here you can see that our first Axia stent, this is the gastrojejunectomy for normal oral intake. We then advanced the scope and tried to find the afferent limb, and we found a loop of bowel adjacent to the stomach. Using the percutaneous drains, we injected dilute contrast, and we could start to see that this limb was filling, and it provided a good window for us to access. So we deployed a lumen-opposing metal stent across into this area, and this was located just distal to the area of obstruction in the afferent limb. We then dilated this tract to allow our standard gastroscopes to advance through it. Once dilated, we actually put a pediatric gastroscope into this area to get a little bit of a lay of the land. You can see here that the proximal end of the afferent limb is obstructed. It looks almost extrinsic. We then tried to advance our pediatric scope through this area. And with a little gentle pressure and under fluoroscopic guidance, we were able to pop through and eventually see the percutaneous drains along with the hepatocogaginostomy with a lot of necrotic tissue and tumor in this area. So I think we had a safe spot and we kind of knew what we were dealing with. So at this point, we were able to get a larger gastroscope across this area. And again, using that angled hydrophilic wire, able to get alongside the right-sided percutaneous drain. And then we were able to remove that right-sided percutaneous drain and stent the right side. And similarly, we did the same thing on the left side. So here you can see our initial cholangiograms and then our bilateral stents. Unfortunately, the patient did have pretty aggressive tumor biology and came in with progressive strictures and obstruction. And however, because of the access that we had, we were able to repeat the ERCP and place multiple stents across that area and eventually relieve the jaundice. In a very similar case, this is a very recent patient that we saw with a Roux-en-Y gastric bypass who had metastatic pancreatic cancer and who presented with jaundice. Many of you are familiar with the EDGE procedure, where we use our lumen-opposing stent to get from the gastric pouch to the excluded stomach and to allow us to do a single-stage ERCP. So here you can see us traversing that lumen-opposing metal stent, which has allowed us to gain access to the excluded stomach. And with that, we can eventually make our way through and perform our ERCP as we would. And so just highlighting that we have this whole armamentarium of tools that allow luminal access, especially in our postoperative patients who need biliary drainage to be performed. So in conclusion, I hope that over the past 30 minutes, I've been able to show that a variety of different techniques that we use to access the bile duct in our patients who have cancer. Traditional ERCP is quite effective. EUS-guided therapies continue to grow and allow us to really treat complex obstruction. Choledochoduodenostomy has a evolving and growing role in managing malignant biliary obstruction, and our EUS technologies are allowing us to really help with postoperative patients and luminal access. I will say, though, that I've showed a variety of different techniques over the last 30 minutes. It's important to note that in this session, we embrace the true multidisciplinary approach that's needed for these patients. The right solution at my institution may not be the right solution at your institution, and it really takes a conversation with your surgeons, your interventional radiologists, and your oncologists to really find that right therapy for your own institution. With that, I thank you for your time. I'm sorry I won't be able to take any questions because this is virtual. However, please feel free to email me if you have any questions about what I presented. Thank you.
All right, great. Thank you so much. Just very quickly, by the way, just invite everybody on this side. If you're happy where you are, that's fine. But if you want to move over to the other side so you can see the screen or not, it's up to you, obviously. I have the privilege of working with Kumar Krishnan. I'm a surgeon at MGH, and he's our kind of go-to advanced endoscopist who does a lot of the malignant biliary obstruction work for us. And you can see sort of the scope of the work that he does. I love the picture of the angry surgeon. I hope we're not always as angry as that when negotiating, but we are a true multidisciplinary setting, and I think it's really important to engage the surgeons in the preoperative cases at least. Just out of interest, how many surgeons in the room? Yeah, all right, so we've got a good number of surgeons. Any experience, good or bad, with some of these, at least the newer kind of EUS-directed approaches compared to ERCP that anybody can think of or comment on, or we can talk about it sort of later as we come to some of these case discussions as well. I will say, just in my opinion, I would just say that for resectable tumors that are eventually going to go to the OR, where the surgical approach, if there's ever going to be cure, is going to be mandatory, I think that having a complication that prevents surgery from preoperative biliary drainage should be approached as a never event. I get it kind of for more advanced tumors and things like that, but if a patient had a chance to go to the operating room, we really just have to be very careful. And so this is where the angst comes from, I would say, in the surgical circles about ruling out some of these patients for operation. But again, if anybody has any sort of positive or negative thoughts about some of the experiences they've had as well, we're happy to take any comments.
I think sometimes you run into a situation where a patient is like a terrible surgical candidate, and then you deploy some of these more aggressive maneuvers, and then when that goes wrong, now you're put in a sometimes tough corner to do a terrible operation on the terrible patient. But I think working together to almost prevent that from my priority and saying, you know, if this goes bad, what are we going to do? And there's a lot of endoscopic salvage for those patients too when things go wrong. But I think having a lot of those tools in someone's armamentarium can be profoundly helpful. As complicated disease and complicated anatomy, whether it's benign or malignant, is becoming more and more common. We're going to move on to the next presentation. Is Dr. Margot Mustian from University of Alabama about surgery approaches to benign biliary obstruction.
Great. Well, thanks so much for the opportunity to present here today. I'd like to first start off again by thanking the organizers, the DDW and SSAT, for the opportunity to present. My name is Margot Mustian. I'm from the University of Alabama at Birmingham. I'm an MIS surgeon there, and we'll be discussing MIS approaches for benign biliary obstruction. So switching gears a little bit from our last talk. I have nothing to disclose. Again, for the purposes of this talk, we'll be talking about benign biliary obstruction as opposed to malignant from the last talk. And we'll begin with talking about differential diagnoses, management options, surgical or MIS approaches, comparison of management strategies, and then special or anatomic considerations that might alter our management. Starting off with differential diagnoses. So the differential diagnoses for benign biliary obstruction, of course, ruling out malignancy is important from the get-go, as again, we're talking about benign disease right now. But for etiologies of benign disease, gallstones certainly contribute to that, including choledocholitis, cholangitis, cholelithiasis, and cholecystitis that can all eventually lead to biliary obstruction. Biliary strictures can be secondary to post-surgical events such as cholecystectomy or history of liver transplant, as well as inflammatory processes, including primary sclerosing cholangitis, other congenital causes, infections, or other rare causes. So the management strategies for these patients with benign biliary obstruction can really be multifaceted, and that includes medical management, and some of that's aimed at symptomatic relief or antibiotic therapy for cholangitis. Endoscopic management, that of course we've talked about a little bit already, can include ERCP for stone removal, stent placement, and stricture dilations, sphincterotomies for choledocholithiasis, and endoscopic biliary stents for long-term relief as well. Percutaneous management is also an option for these patients. That includes biliary drainage for temporary relief, as well as stenting for benign biliary strictures. And then, of course, today, the purposes of this talk is to focus on surgical management. So we'll kind of highlight that. And most of the talk that I'll be presenting today will be related to cholecystectomy and gallstone-related obstruction with laparoscopic common bile duct exploration. Certainly, there's also other operative interventions for strictures and tumors, including biliary bypass procedures. Many of these are still done open, but some are also done MIS. As an MIS and bariatric surgeon, again, I'm going to mainly focus on this first category here, focusing on gallstone-related obstruction and the role for laparoscopic common bile duct exploration. So again, beginning with this first item on our differential diagnosis. So that gallstones are very prevalent. More than 20 million patients in the United States have ultrasound-detected cholelithiasis. And then we know that the prevalence of that has actually been increasing recently as well, both for just the diagnosis as well as for the role for cholecystectomy in both men and women in the U.S. over the last decade. We do know also that choledocholithiasis accounts for roughly 2 to 20% of patients with cholelithiasis. And this also might be an underestimation of that, as some of these choledocholithiasis patients are not actually diagnosed without the routine use of intraoperative cholangiogram. So what are our management options for benign biliary obstruction? So really for management of choledocholithiasis, it really boils down to 4 main options. The first 2 options both include the role for ERCP, and then the only difference between the 2 is kind of the role of when ERCP is performed, whether that's preoperatively or postoperatively in conjunction with cholecystectomy. I guess one caveat to that would be that for option 2, there are instances where ERCP is performed but then not followed by cholecystectomy, so that would be one other deviation of that. Option 3 includes cholecystectomy with an intraoperative ERCP. And then finally, option 4 is cholecystectomy with the laparoscopic common bile duct exploration at the same time. I say laparoscopic here, but this really could be any MIS approach. Alternatively, could be open, but again, for the purposes of today, mainly referring to a laparoscopic approach. So there's multiple different algorithms that have been circulated. Many of them are conflicting and complicated with different limbs and pathways. Some include MRCP, some do not. So I think instead of focusing on an algorithmic approach, I think it's important to highlight some of the important management considerations. So for patients that present with symptomatic cholelithiasis and are also found to have choledocholithiasis, I would consider laparoscopic cholecystectomy with a common bile duct exploration. This is, again, a little bit of a difference from our historical approach, what we've been doing most recently. I think in the open era, common bile duct exploration was much more prevalent, but then with the rise of ERCP, the comfortability that surgeons have had with laparoscopic common bile duct exploration had decreased, but I think we're again seeing more of a rise in recent times, and so that's why I would advocate for including this again in our algorithm up front. Certainly for patients with cholangitis or gallstone pancreatitis, ERCP up front is more appropriate. And as we talked about before, patients with malignancy concerns, again, further workup is necessary prior to any intervention. There's also going to be patients that are not great surgical candidates. So for patients in septic shock or other reasons that would stray us away from the operating room, there's still other adjuncts available, such as decompression with percutaneous cholecystostomy tubes. But again, I think when we think back about our options, our management options for choledocholithiasis, it really kind of boils down to what tools do you have available for you in your toolbox. And with that, again, it boils down to ERCP plus cholecystectomy before or after, and that's compared with MIS cholecystectomy with a common bile duct exploration. But what's the current state in the US, and how is choledocholithiasis typically being managed? As I talked about before, I think there was a time when common bile duct exploration was more common from an operative standpoint. With the rise of ERCP, that's really become the mainstay of treatment up front, followed by cholecystectomy. This was a retrospective review in which patients undergoing inpatient management of choledocholithiasis were identified from the Healthcare Costs and Utilization Project. Availability of ERCP was determined based on the American Hospital Association survey. And the proportion of common bile duct exploration, ERCP, or percutaneous interventions were compared across urban and rural classes. And during this study period, there were 111,021 instances of choledocholithiasis reported based on the hospitalizations in the US, and of these, about 67% had coded intervention. So roughly 70% or 67 to 70% of patients had some sort of intervention. And this table shows the interventions by rurality, with urban patients shown in red and rural patients shown in blue. And certainly there was a much higher use or higher intervention rate in the urban areas compared with rural, leading us to think that there might be better ways to intervene in those areas that don't have as much access to interventions for their choledocholithiasis. When they looked again by rurality at access to ERCP, ERCP was underutilized in the rural patients compared with urban patients. But interestingly, common bile duct exploration was similar between the two groups, but kind of trended to a higher utilization among rural patients. I think this really highlights the need for interventions in areas that don't have access to advanced endoscopy or to ERCP. And this really might be an area where advancements in laparoscopic common bile duct exploration can really be utilized. So with that, again, we'll focus again on the surgical or MIS approach to benign biliary obstruction for choledocholithiasis. And when we consider a laparoscopic approach, the first thing that we really need to kind of consider is what our feasibility is with this intervention. So for a transcystic common bile duct exploration, what's the feasibility? And a lot of things depend on the patient presentation and the anatomy. So stone size and stone location are important. The stone location in the common bile duct versus common hepatic ducts are necessary for a transcystic approach. Stone size that's smaller than 6 millimeters also is more feasible or more amenable to a laparoscopic approach. Fewer stones also is going to lend more to the feasibility of a laparoscopic or MIS approach. And then the cystic duct insertion also can play a role, again, depending on where it inserts, how much of a length you have on the cystic duct, and if it's not low or medial. So again, thinking about your other options, if the transcystic approach is not available, again, post-op ERCP is always an option, as well as a transcholedochal common bile duct exploration. We'll talk about that a little bit more in detail as well. Again, this is another study that demonstrated there were certain factors that influence approach. Again, most of these are related to the nature of the stones, the nature of the ducts, including the cystic duct and common bile duct, and then surgeon comfort level or suturing ability. So for consideration of laparoscopic common bile duct exploration, for surgeons that are earlier in their learning curve, really starting with patients that have symptomatic choledocholithiasis with a dilated common bile duct and a single distal stone, that's going to be the best patient to get started off in your learning curve, as opposed to more complicated cases. However, in the absence of contraindications, I would advocate to consider common bile duct exploration for most patients, and then start to rule that out as opposed to ruling it in. So for an MIS common bile duct exploration, still begins with a standard port placement, just as you would for any laparoscopic or robotic approach. No need to deviate from what you would normally do from that standpoint. Certainly then, if possible, obtaining the critical view of safety is important. And then just starting with a cholangiogram, and that really aids in determining the plan for approach. So the setup for an intraoperative cholangiogram, having a 5-French open-tip catheter, and then mixing contrast and saline 50-50. Whenever possible, if you see stones in the cystic duct, milking those retrograde first can be really beneficial as well, so you're not fighting those and having to go retrieve those after your cholangiogram. And then identifying the choledocholitis, and that can be identified via filling defects, meniscus signs, or the duodenum not filling. There's certain adjuncts that can be used here as we typically would in an intraoperative cholangiogram, and that includes glucagon and saline flushes. And then once you kind of have your landmarks and what you're going to be trying to target or go after, you can then start with your laparoscopic choledocoscopy. Again, your necessary supplies for that are going to be a flexible choledocoscope, a floppy tip guide wire, a second video monitor. Now that may not always be necessary depending on what kind of scope that you have. Pressurized saline with tubing, laparoscopic graspers, stone retrieval basket, and then optional adjuncts are balloon dilators, and then if you're planning to do lithotripsy, also having a lithotripter. So the first step is just gaining access to the biliary tree through your transcystic catheter, then placing your guide wire through the cholangiogram and into the duodenum. Again, needing an open-tipped cholangiogram catheter for this to facilitate the guide wire placement. Next, you'll remove the catheter and leave the wire in place, stabilizing the wire to ensure it's not dislodged. An alternative step 3 that's optional is the dilation of cystic duct valves under fluoro. If the cystic duct is large, this may not be needed. And again, you don't want to dilate larger than the common bile duct diameter. Next, you'll introduce the choledocoscope over the wire, and it's important to have continuous irrigation during this step, again, to prevent stones from going up into the common hepatic ducts. Step 5 is placing the choledocoscope through the biliary tree proximal to your obstructing stone, and again, continue irrigation with saline, with your cystotubing. That helps with visualization and again prevents retrograde flow of the stones. So I think at this point you're really trying to figure out what your ultimate goal is going to be, and that's how you're going to manage your stones. That includes the ability to push stones through the ampulla, snare them, crush them, or extract them with the basket under direct visualization. So that leads us to step 6, which includes removing the wire and advancing the basket through the working channel in order to capture the stone, then pull the choledocoscope out of the biliary tree to remove the stone, keeping it close to the scope to watching it come out. Again, the other option is pushing it distally or slicing it to fragment to smaller pieces. Again, as we talked about before, irrigation during this step is really beneficial. So once the duct is cleared, it's imperative to repeat the cholangioscopy to confirm the clearance, and again, withdraw slowly here to make sure you're not leaving any stones behind, and then perform a completion cholangiogram. So we talked about feasibility of the transcystic approach. However, if the transcystic approach is not available, the other option is a laparoscopic transcholedochal common bile duct exploration. However, I would say with this, there are significant bile leak and stricture risks. So I would not advocate for doing this early in your learning curve, and certainly should be done in kind of optimized circumstances with people that have done it more and have a lot of experience with that. I would say in most instances, should only really be used if ERCP or other measures are not available. So what are barriers to the propagation of a laparoscopic common bile duct exploration? I think certainly historically there's been some discomfort with MIS techniques, particularly with laparoscopic common bile duct exploration. I also think that kind of changing this paradigm is difficult just due to the way that patients are typically funneled. Most patients that come in with choledocholithiasis, it's not in most people's algorithms to go straight towards a surgical approach, so that does require a little bit of a change in both consulting services and then a way just of managing patients generally. And then also the availability of resources and equipment that's needed to perform these procedures. Oftentimes, as has not really been utilized that much recently, there is lack of familiarity with the OR staff, and that can lead to some hindrance as well. So what are some facilitators then? I think increasing surgeon comfort with MIS techniques, and perhaps sometimes with the robotic platform as well, has led people to consider adoption of laparoscopic common bile duct exploration when they wouldn't have in the past. Additionally, advances in cholecystoscopy has really been beneficial, use based on the single-use disposable cholecystoscopes that have made the process of obtaining them and using them much more simpler with better imaging as well. And I think importantly, there's also many opportunities for advanced training and simulation, and that's for both practicing surgeons and trainees alike. And I think this is another great way to kind of increase the access to this important modality. And one institution has demonstrated that after implementation of their laparoscopic common bile duct exploration curriculum, they certainly found that the percentage of patients with choledocholithiasis that were treated with common bile duct exploration before and after the curriculum implementation certainly had a dramatic increase. And again, we're still talking about low numbers, but increased from 1.9% before the curriculum to 8.4% after the curriculum. So it's obviously still a role to increase its utility. So comparison of management strategies. So how does the laparoscopic approach compare then to the standard that we typically would utilize, including ERCP? So certainly there are many benefits to ERCP, great stone clearance. It is an endoscopic approach, so it's less invasive than a laparoscopic approach, but certainly if patients are having a laparoscopic cholecystectomy later on, that may or may not play into the role here. There are some studies that have demonstrated lower immediate complication rates, but certainly there is a risk for post-op ERCP pancreatitis, hemorrhage, perforation, and again is limited to facilities that have endoscopic expertise and availability. And this kind of goes back to what we were talking about earlier with rural and urban centers. Certainly there's a lot of rural areas that don't have access to advanced endoscopy, but do have access to an OR. For laparoscopic common bile duct exploration, again, the benefits, there are similar stone clearance compared with ERCP. And some studies have demonstrated similar morbidity and mortality compared with ERCP with fewer numbers of procedures performed. I think this is really where it gets to the advantage or the benefit of the laparoscopic approach, mainly in the findings that there's really only one procedure that a patient has to undergo compared with having multiple rounds of anesthesia, multiple intubations, and multiple procedures. And really because of the number of procedures performed, this tends to make the hospital's length of stay shorter and has therefore been associated with a lower cost. However, as we talked about before, there are certain limitations. I think a lot of this is related to expertise and training. Certainly we have a ways to go as far as more widespread adoption of this approach. And again, the logistical planning can be challenging as well, particularly with OR staff being unfamiliar. So when we compare the procedures kind of head-to-head as far as outcomes go, there have been multiple randomized clinical trials that have looked at outcomes following lap common bile duct exploration with laparoscopic cholecystectomy compared with ERCP in addition to laparoscopic cholecystectomy. And what the vast majority of these studies have found, the big takeaway is that there's similar outcomes between both approaches, but a shorter hospital length of stay with laparoscopic common bile duct exploration. And again, this typically boils down to the fact that it's a one-stage approach as opposed to two-stage. Instead of patients waiting multiple days for multiple procedures, just undergoing the one and then hopefully being discharged shortly thereafter. So this was a large meta-analysis that also captured post-operative and post-procedure complications and outcomes and compared the one-stage and two-stage approaches. This study also included common bile duct exploration as well as lap chole and ERCP pre or post-op in addition to lap chole with intraoperative ERCP. And when they looked at length of stay, really the only their significant finding was a decreased length of stay with common bile duct exploration compared with preoperative ERCP. Again, when they looked at overall complications, the rates were really similar between the groups. However, with looking at bile leak, this was more commonly reported among common bile duct exploration compared with preoperative ERCP. And pancreatitis was more prevalent among patients that had undergone ERCP, not surprisingly. When looking at recurrence rates for the stones, this was a retrospective analysis that looked at stone recurrence after 6 months greater than 6 months after initial clearance. And this looked at a total of 604 patients with confirmed common bile duct stones. And these patients either underwent laparoscopic common bile duct exploration or ERCP pre or post-op, and some of those patients also had a laparoscopic common bile duct exploration as well. And then there were several patients just in the ERCP only group. When they looked at time to recurrent stones, there were really no significant differences between the lap common bile duct exploration only and ERCP only. But with lap common bile duct exploration and ERCP compared with just laparoscopic common bile duct exploration only, there was a difference in the time to recurrence. And then their multivariable analysis, when they looked at indicators of factors that were associated with recurrence, the only thing that was really significant was the total number of procedures that they had to have performed in order to clear the first time, with an odds ratio of 6.9. So moving on then now to special or anatomic considerations. The first special consideration would be the elderly population, and I think this was a population that previously was thought to maybe be better managed with endoscopic management alone, and trying to avoid an operative intervention. But there was a retrospective study of 160 patients that was performed in patients that were over 70 years old, again comparing laparoscopic common bile duct exploration with ERCP and laparoscopic cholecystectomy. And they found, again, similar to other studies, the main difference was the length of postoperative hospitalization, with a length of hospital stay of 8 days in the one-stage group compared with 14 days in the two-stage group. So the kind of takeaway message from this paper was that for elderly patients, the efficacy and safety of laparoscopic common bile duct exploration with cholecystectomy was comparable to those of preoperative ERCP followed by laparoscopic cholecystectomy. And again, with a shorter length of stay. I think this, again, boils down to the fact of patient selection and just making sure that patients are appropriate surgical candidates in the first place, as both of these groups did have an operative intervention. And then moving on to other anatomical considerations, surgically altered anatomy certainly can play a role in our approach to patients, particularly patients that have had a prior Roux-en-Y gastric bypass or any other reason to have Roux-en-Y anatomy. Again, these patients can be managed with laparoscopic cholecystectomy with common bile duct exploration, or alternatively with a laparoscopic-assisted ERCP. And a lot of this depends on the timing of the diagnosis of the choledocholithiasis, if that's preoperatively before their cholecystectomy, or intra-op or post-op. This video will show one approach for laparoscopic-assisted ERCP, where we're going in and identifying our excluded stomach and freeing that up so they'll be able to pull that up to the abdominal wall. We're placing our sutures. And this is going to aid and facilitate passage of the ERC, or of the scope for the ERCP. The gastrotomy is then performed. And then the tract is dilated. You know, one drawback to this is, again, this requires coordination of multiple teams and availability of advanced endoscopists and surgeons. Now the bowel is going to be clamped distally, again, to facilitate the passage of the ERCP. Now the scope is actually placed through the port and then into the excluded stomach. And then from here on out proceeds just as an ERCP. So the SAGES Guidelines Committee in the past had demonstrated obviously different options for management of choledocholithiasis in gastric bypass patients. Again, surgical therapy is an option, as we just as we've been talking about through most of this talk. But there's also a role for endoscopic therapy, and that's through balloon ERCP, the lap-assisted transgastric ERCP, like we just watched, and then also with the EDGE procedure that was alluded to in our last talk. Certainly, if these are not available options, then percutaneous therapy with percutaneous biliary drainage is, again, another option. So for those considering adoption of laparoscopic common bile duct exploration, in light of the meeting, be gutsy, but also there are some certain tips to consider for adoption of laparoscopic common bile duct expiration. This is a recent paper that was published about a month ago with tips for those considering adoption. And I would say the first one is be wary of the concept that the laparoscopic common bile duct expiration is simple. So do be gutsy, but be aware that it's not always just a simple approach. It does take a lot of time and effort, but it can be safely adopted with invested time and effort. Don't go it alone if possible. So if you have other partners or other people willing to learn it with you, that's also very beneficial. And as we talked about before, improvements in technology have certainly helped to decrease the learning curve and decrease frustration along the way. Creating a local protocol that will funnel appropriate patients to laparoscopic common bile duct expiration can be really helpful as well. And then meeting with local industry reps can be very beneficial, not only to review the equipment and what you need to have success in the OR and get set up, but also to get training with the simulator and get more exposure. Another important thing that the authors had mentioned in this that I would advocate for as well is starting with a routine IOC for all cases, just to gain more comfort and ease with that part of the procedure. Getting the deep wire access is key to success for the transcystic approach. And importantly, knowing indications and contraindications for the transcystic approach and all the adjuncts available. As we mentioned before, choledochotomy is an option for complex cases, but again, should really be limited to those patients that have a dilated common bile duct and based on surgeon comfort, and certainly would not be an easy way to get started on the learning curve. And finally, and importantly, don't forget that it's acceptable to bail out and just perform a lap chole for difficult cases with the safety net that there is an option for post-op ERCP or PTC afterwards. So to wrap everything up, I hope that you, based on this information, will consider the role for laparoscopic common bile duct expiration for patients that are presenting with choledocholitis. Again, this is kind of a change in the algorithm and typical management, but I think it's one that may be really important for our patients. However, a multidisciplinary approach is extremely helpful, particularly for patients with very challenging surgical and medical histories. The one-step approach is likely beneficial for many patients when it is feasible, with decreased length of stay and comparable complications compared to our current paradigm. However, a need still remains for additional training and adoption of laparoscopic common bile duct expiration if there's going to be any algorithmic changes to occur for the management of benign biliary obstruction. Thank you so much for your time and attention. Again, I'd like to thank the organizers and happy to take any questions.
I don't know if anyone has any questions. Feel free to come to the mic. But it almost seems to me that double balloon ERCP every 5 years is becoming more and more difficult, just of the nature of that. There's all these other tricks. Because I vividly remember 7 years ago being semi-commonly performed with pretty high success. But what's your take on LAMs for benign disease, like getting gastrogastrostomy or a roux gastrostomy to then get access to the biliary tray for benign disease, where you're looking at a 12-year or like 10 or 20-year outlook versus malignant disease, where that timeline may not be that relevant.
Right. I think we were kind of talking about that a little bit after the last discussion. I think it certainly has its merits, but I think dealing with potential complications can be really challenging, particularly with recurrent strictures or things like that in those procedures. I think we still don't really exactly know. I think there's some excitement about it, but I think we don't really know long term what that's going to look like for the safety for patients.
It seems like when the literature for dealing with the primary gastrogastric fistula shows not amazing results, but it does show that it works, like closing a LAMS defect seems to work for the most part. So it's definitely being employed more with less concern. But you're right, there's a lot of tools in the armamentarium, as you showed here.
Hi, great discussion. Thank you so much. I just had a question. I saw that there was a size restriction for the stone, 6 millimeters or less, to do a common bile duct aspiration and removal. Is that because of the distal sphincter and then more proximally the cystic duct diameter, or why is that limitation for the size of the stone?
Yeah, it's mainly related to the size of the cystic duct and being able to remove that. Now, that's, I would say, a relative number. I think that's a good number to start with if you're early adopting of this, but certainly stones, as we mentioned before, can be pushed distally. They can be broken up as well. So I would say that's not a hard and fast rule, but certainly when you're thinking about what's going to make it more amenable to a transcystic approach, that's where that number comes from.
Is it a completely heinous crime to ask an MIS surgeon about the robot here? A robotic CBDE probably allows more surgeons to be able to participate in the process compared to laparoscopic, and then the addition of ICG and Firefly and other benefits from that.
Absolutely. And I would say, I use the term laparoscopic, but really I meant more of an MIS approach, and that I think whatever you're more comfortable with in general is what you should use also when you're, trying to adopt a new technique.
Thank you.
Thanks.
Any other questions? Anything? All right. So rounding up the afternoon, complex case presentation and group discussion, our good friend owner. Thank you so much for being here. However you want us to interact with you, let us know.
No, I'm good, thank you. Yeah, great, wonderful. Thank you for staying, it's late in the afternoon. My name is Omer Kutlu, I'm from the University of Miami. All right, so please feel free to make comments during the presentation because it's going to be a group discussion on the cases. Why am I giving this talk? Because, let's see. All right, we can do this. Because majority of my practice basically minimally invasive pancreas. However, because of my bariatric background, I do bariatric surgery in high-risk patients and their complications. So this bile duct exploration business got stuck to me at the university. And thanks to my colleague, Dr. Barkender, I don't have any shortage of cases. So this talk is going to be divided into a 5-minute introduction and 4 scenarios. The general surgeon and the gastroenterologist is going to have 2 major scenarios. One either is going to be a post-bariatric surgery, altered GI anatomy, or altered GI anatomy to the non-bariatric procedures. Unfortunately, for post-bariatric surgery patients, Roux-en-Y gastric bypass, duodenal switch, mini or one anastomosis gastric bypass, the biliary tree is practically not accessible despite what the literature says. And here's what the reason is. For the Roux-en-Y gastric bypass, in the olden times, the limb lengths were usually around like 75 to 75 centimeters. It's gone up to like 200 centimeters right now, total bypass length. For the mini gastric bypass, what you have is a long gastric conduit and a anticolic, antigastric gastrojejunostomy similar to a Bill Roth. You have a 200 centimeter biliary limb. And for duodenal switch, you have almost 350 to 500 centimeters of bypass. I mean, it's going to be impossible for duodenal switch. For the other ones, it's really going to be very hard to do this in conventional endoscopic ways. The only advantage of the other 2 procedures, you basically have the gastric remnant if you want to access the biliary tree through a transgastric ERC piece. On the other hand, when you have an altered GI anatomy due to non-bariatric procedures, it's way easier because like when you have a Bill Roth 2 reconstruction with a Brown or without a Brown anastomosis, your distance is going to be 40 to 60 centimeters, which is accessible with a good gastroenterologist. Similar for Roux-en-Y reconstruction, it's around a 100 centimeter bypass. We routinely can access the papilla through these. And for Whipple's also, you have around 60 centimeters distance from the gastrojejunostomy to your pancreatic anastomosis and to your biliary anastomosis. So our options on IR versus GI versus surgery, I mean, I always hate to say it depends, but it really depends on the patient, the facility, the expertise. Literature less than above because it's hard to replicate. It's been written by endoscopy Jedi masters, which is hard to replicate for mortals like us. And also the timing from the surgery is an important factor. a patient who had recent surgery, there's very little data regarding endoscopic interventions within 30 days. We know that there's been reports of using endoscopy in recent patients for bleeding, stenting, diagnostics, sometimes for dilatations. However, there's concerns of air insufflation, local endoscope trauma, and more importantly, torque in this patient group. So surgeons are not very happy about doing endoscopy early and after surgery. However, we know that it's safe and effective for diagnosing and treating anastomotic leaks, and Mayo Clinic's data says that maximum tensile strength goes at 4 weeks after surgery, then you can safely do endoscopic interventions. However, on a patient with recent surgery, less is more. Surgery is not ideal. You don't have a dilated bile duct, and the complications are hard to manage because GI can't help you. It's very hard for them to help, and GI for surgeons is our superheroes. They save us all the time. So although our goal is to treat the patient, but in the early scenario, oftentimes temporizing the patient becomes more of a priority. For surgery after 4 weeks, it's still less is more because surgery is hard. It's not like YouTube. It's not like presentations or the courses. You need to be familiar with the instruments, with the anatomy. You still have a GI help, but limitations are there. Again, we like to treat. You may need to temporize the patient. However, now you have more options because you have a compensated patient, and GI may be a little bit more aggressive compared to the others. So this is a real-life scenario. This patient came in a couple of weeks ago. 40-year-old female, status was room-wide gastric bypass 5 years ago, presents to the emergency room with right upper quadrant pain and jaundice. So if we look at the labs, T-bili is 5.6, alkaline phosphatase is 1,300. This is another one. Again, this came a couple of months ago. Total pain, 44-year-old female, history of room-wide gastric bypass, 100 centimeter biliary, 100 centimeter biliary limb, chronic recurrent pancreatitis, referred to T-PATE, abdominal pain, biliary dilation, elevated biliary limb for the first time, and MRI is biliary ductal dilation, then this is the common bile duct calculi. So let's go to real-life scenario one. So this patient presents to your ER, and you're the gastroenterologist or surgeon on call, and you get a CT scan, and you see this 1.2 centimeter distal common bile duct stone in this patient. What would you do from now on? What would our options be? Does anyone have any ideas or any recommendations for this patient?
Clearly the recommendation is to transfer to the University of Miami. But apart from that, it depends if they have their gallbladder in or not. It sounds like they do.
Yeah.
So then, it's a large stone, right?
Yes, correct. It's a 1.3 centimeter stone, sir.
So, in my hands, I would take the gallbladder out and do intraoperative transgastric ERCP.
Yeah. So that's in fact one of the traditional options for the ERCP and room-wide gastric bypass patients. Everyone's talking about this double balloon endoscopy. At UM, we don't have it. We have a single balloon endoscopy. Correct me if I'm wrong, Jody. But often places, I talked with Baryam Abudaya from Mayo. He said, look, we don't deal with this double balloon thing. The success rate is very low. So we took the patient for a laparoscopic assisted ERCP. Now, for the lap-assisted ERCP, what I do is I function en masse, meaning I perform everything before the GI starts scoping the patient. The gallbladder is removed. I leave a long cystic duct stump with a endoloop PDS tied around it so I can manipulate the bile duct if I need to do a transcholecystic or transcodical bile duct exploration. And then because the thing is, if you don't prepare the surgery to be able to bail out at any time when the GI insufflates the bowel, although they use carbon dioxide, you may have a lot of bowel in your face, and it may be hard for you to complete the procedure. I use a 15 millimeter port. Sorry, this case was again recent. I couldn't edit the video, but I use a 15 millimeter port. We use 12 millimeter ports. Remove the cap off. Despite lubing it, the ERCP scope does not go through, but therapeutic endoscopes go through. So we use a 15 millimeter port, and the first step is to understand which side where the stomach is going to reach up. After that, I torque the the port, and right behind it I suture the abdominal wall with V-lock sutures, and also I suture the gastric the gastric remnant to the abdominal wall. And it's done loosely and circumferential around the port. It looks tight right here because you have a 15 millimeter port. I found this way to be the safest way to do it. Any other technique that we have tried, and we see a lot of these, as the GI is performing the ERCP due to the torque, sometimes the stomach pops away from the port and you get contamination, and also it makes it hard for them. And once you have it like this, you can desufflate the abdomen. Gastroenterology loves it when the abdomen is desufflated because the angles are easier for them to be able to access the bile duct. Once everything is done, when you remove the port, you see that it's loosely approximated to the abdominal wall. In presentations, people talk about doing purse string sutures and other things around the stomach to close it up. I mean, that can happen in the perfect environment where there is no gas inside the abdomen. However, when you have a dilated bowel in there, this is perfect because all you need is one simple staple shot. And once you do that, you have very little amount of tissue up there, and it's basically out. So I'm not going to talk about edge. Edge procedure, basically, you perform a lumen opposing stent at the between the stomach, gastric conduit, and the gastric remnant. Oftentimes, what I've seen with edges, it's done between the alimentary limb of the bowel and the gastric remnant because it's easier for the GI to access it. Oftentimes, the gastric conduit and the stomach is retracted. So the advantage of this, if you have multiple distal column bile duct stones, this allows you to go back again and again to do multiple interventions in that area. There are gastroenterologists mostly in this room, so I'm not going to talk about your specialty. Please, I apologize if I'm stepping on your toes, and I'm more than happy to listen to your experience on this. So this is another scenario. 73-year-old female, status post-open Bilirubin 20 years ago in Cuba, seen by gastroenterology for bioreflux, abdominal pain, anemia, was seen to have an anastomotic ulcer, bleeding, and she failed maximal medical management, and she was referred to me for conversion to revision of the anastomosis. So when I'm going to do these things, I always do right upper quadrant ultrasound. She did not have gallstones, and she has a history of breast cancer. So a couple of years ago, she had an MRI done. She had a PET scan, then a CT scan of the chest and pelvis done. No stones, but she has persistent common bile duct dilation. So we said, okay, that may be due to her age. And we took the patient to the OR for a laparoscopic gastrojejunectomy, conversion to a Roux-en-Y gastroject, 50-50 limbs, and the patient develops right upper quadrant pain post-op day 2. So she becomes jaundice in day 3, and these are her labs. And then I started sweating. Because I'm thinking about, what did I do? Did I cut the bile duct? Did I clip it? I know that there's a big bile duct. I can't do that. And then I ordered an MRI. It was a very long 30-minute wait for me, and this is the image. Now, this is a problem. I'm relieved it's only a stone, but now what are we going to do? We have a fresh anastomosis. We have a 100-centimeter bypass limb. I have difficult anatomy. And what are the options at this point from the audience? What would you do?
I think,
That's this Motaz category.
I mean, I think, again, we just have to be mindful of all the options, but an IR-PTC could be a good option here and fish it up from above.
Yeah. So what we did was, so I talked to IR to place a PTC catheter. We have a very talented IR, a couple of IR people who are dedicated to HPB. So they look at the MRI and they said this patient has a pretty large cystic duct. So we may place a cholecystostomy tube, and we may try to extract that stone through a transcholecystic approach. And I did not argue too much with them at that point, and it sounded like a good idea, so we did that. When you look at the options, we can perform percutaneous transhepatic instrumentation of the common bile duct. We can do it for drainage, for lithotripsy, for stone extraction, for stenting. There are myriad of things. So we tried the last option, which is percutaneous transcostotic removal of common bile duct stones, but our first choice was to temporize this patient. So the limitations of percutaneous approaches to this common bile duct stones by IR is stone size over 13.5 millimeters and common bile duct size over 15.5 millimeters. And I'm going to get to the reason for that. Also, common bile duct angulation, like this patient, is a common contraindication or difficult source of difficulty for this. How it's performed is IR places the balloon into the papilla. This common bile duct dilates the papilla and retracts the balloon back and then inflates the balloon into the bile duct. Now you have proximal blockage of the bile duct and power flush this. However, if you have a large bile duct, you cannot have that seal. Therefore, it's hard for them to flush this. Obviously, angulation is a problem also. Their other option is, in these cases, would be to, again, dilate the papilla, and there's lithotripsy. Baskets which can forcefully fragment these stones and allow them to flush this. Again, pretty acceptable complication rates and success rates with these. And the other option is to a transhepatic choangioscopic lithotripsy. It's a time-consuming process. You temporize the patient by internal and external stenting, and you upsize the stent to 14 to 16. 14 does not work. We tried it. You have to upsize it to 16, and it takes like weeks for this to happen, and the patient is walking around with a PTC catheter coming out. They really don't enjoy it. And the last one was what we wanted to do, percutaneous transcholecystic approach to take that stone out. This is an image where we managed to, where a transhepatic stone extraction is done after a dilation of the tract to 16 French. So we planned a rendezvous. ERCP stone removal was unsuccessful due to angulation of the bile duct. Our gastroenterologists were able to access the papilla, but however, we couldn't get the stone out. And now what are we going to do? What would your options be at this point? We have a cholecystostomy tube. The patient is stable, but we can't get the stone out.
Anyone like to comment from the audience? I'm happy to answer all the questions, but I'll share the wealth. Anybody? Any options? You can just yell it out. You don't have to come to the mic.
Surgeon extraordinaire, Dr. Katan.
Well, I know how to do hepatic jejunostomy pretty well, so that is an option. You just have to reconfigure that with the anatomy that you have now, which is already Roux-en-Y anatomy, so you'll just have to plug it into a separate limb and do so. But for an impacted stone in the distal common bile duct, you could do that.
Okay.
Go ahead, sorry.
Extracorporeal
Extracorporeal lithotripsy.
Why not? Why not? I don't have much experience on this. I cannot comment, but here's what my thought process was. So I was either going to upsize the drain and attempt percutaneous lithotripsy and stone extraction like you recommended, or I was going to go to the patient and lap cholecystectomy and laparoscopic bile duct exploration. However, 2 days later, this happens. So this old mama, she's very stoic. She loves us, and she has awful abdominal pain. And her lipase goes up to thousands, and now there's free fluid by the pancreas, and there's a lot of inflammation in the area, and I really don't know what to do with her. And so now the OR option is out. No one wants to do anything else at this woman, and we say, okay, we're going to wait. Let's not abuse this woman more. Let her calm down a little bit. So we waited for 4 more weeks. She developed necrotizing pancreatitis, and she had saponification ahead of the pancreas, so I went in, and this is what I saw. So I did a necrosectomy at the head of the pancreas to be able to reach the bile duct and expose the cystic duct, and later I placed a corticoscope into the cystic duct. The cystic duct was like the radiologist, is pretty dilated. I didn't have to do anything, and I took that stone right out. And the cholecystectomy, and she was pretty fine afterwards. She's still going to her oncologist follow-ups, but she obviously does not like me at all. So the other scenario is, this is pretty interesting. 72-year-old male, surgical history of biliary and cholecystectomy. He had an antrectomy done in Cuba way back in time. He was transferred from an outside institution with a jaundice, total bilirubin of 4, multiple unsuccessful ERCP attempts at outside institution, gets a CT scan at and we see a 4-centimeter head of the pancreas mass, less than 180 abutment of the SMV. They tried to do an ERCP outside. They obviously couldn't do it, and there was a massively dilated biliary system, and the left duct was very prominent. It was right next to the stomach. So we tried to go in to do an ERCP on this patient. We managed to get a transgastric biopsy of the mass. It's invasive adenocarcinoma. However, no matter how much we tried, our gastroenterologists, despite everything, they were not able to cannulate the bile duct. Now what are we going to do? Any thoughts?
I mean, similar to what we saw in the first talk, were they able to EUS?
Yeah, so that's why I asked if Krishnan is here, because he gave a similar talk at the AHPBA. I was going to ask for his comments too, but Dr. Barkan is here too. He does these a lot. So what we did was we did a EUS-guided hepaticogastrostomy. The reason we were able to do this, at first our thought was to to perform place a PTC catheter, later do a rendezvous procedure on this guy. However, the dilated bile duct was right next to the stomach. It was not going to be much of an issue. So a 1 centimeter by 8 centimeter covered metal stent was placed. And then we placed 2 double pigtail stents inside the ductal system. Now, for the hepaticogastrostomy, good God. Sorry. For the hepaticogastrostomy, so it's a procedure. Yeah, thank you. It's a procedure reserved, especially reserved for patients who are inaccessible to papilla due to tumor invasion in surgical alternate anatomy, like this patient, and failed biliary cannulation. It's been reported to have a clinical success rate of 94% and pretty acceptable stent patency, especially if we place double pigtail stents in these cases. We don't have too many cases, but that's what we do. And therefore, it's easy for stent exchange. And however, in the literature, it's been acceptable complication rates have been reported with these patients. The biggest problem is always a complication that would preclude the patient from receiving their chemotherapy. That would be disastrous in these situations. So it really should be attempted by a experienced team or some surgeon that's on standby that can bail you out if things go wrong. So anyway, the patient received this, started his neoadjuvant chemotherapy. It's been 4 months now. This is the CT scan. The biliary system is decompressed, receiving neoadjuvant chemotherapy. There's an interval decrease in the size of the mass. So hopefully we will wait for completion of total neoadjuvant, and I will do a diagnostic laparoscopy on this guy because there is some liver nodules there, but non-FDG avid those nodules. So I don't know what I'm going to deal with. IR could not hit those. So this is another scenario. 54-year-old female, history of cirrhosis, renal failure, portal hypertension, surgical history of antrectomy, transferred from an outside hospital where they tried to do an ERCP, and she was seen to have a 6-centimeter common bile duct stone, and she comes to the ER with cholangitis. They called me. I said, okay, send her over. Let's see what we can do. So this is the CT scan. As you can see, this big mother stone is occupying the entire bile duct. So we admitted the patient to the ICU, corrected her coagulopathy, gave her antibiotics, called hepatology for optimization. She got her midodrine and octreotide and everything that they give. But what do you do now at this point? This is a very sick patient, humongous bile duct stone, and you can't access it. So, any thoughts? I told you I had fun scenarios. Yeah. Okay.
We're running a little bit short on time, but I would
Okay,
say
all
like
right.
you can actually, you can just do an IRPTC and just temporize the patient for now
Yeah.
and get them better.
Yeah, that's exactly what we wanted to do. But instead of IR, let's attempt the ERCP ourselves. There was a huge papilla. There was a stone in there that we removed, but after that, there was a mushy, big mass in there. We placed 2 pigtail stents in the common bile duct. And this is a picture that I took. This is with a therapeutic endoscope, in fact, that was able to pass through the bile duct, and they couldn't get this thing out. So for this, I bit the bullet. And I took her to the OR. So this is my port placement for my bile duct explorations, lap ripples, bile duct resections, and everything. It's the standard approach, just attacking the right upper quadrant. The important point is to handle the liver very gently in these scenarios, because once they bleed very badly. I think you saw this last year. I showed this too. So the bile duct is completely exposed. I opened the the bile duct with sharp shears. In fact, there is a huge bezoar in that bile duct. After removing all the stones, cleaning up, I closed the bile duct with 4O PDS MH1 sutures for minimally invasive surgery. MH1, I believe, is the best needle to use for bile duct and the pancreas. It's a wide tip needle. So, let me see. Can I go? Yeah. Okay. So that was my scenarios. I'm more than happy to answer any questions. If
We got a
anyone wants to
question.
make any comments.
Do you have any varices around the bile duct? When you are dealing with a case of cirrhosis,
Yes.
if you have varices, it will be very difficult to go into the common bile duct. It's peridocal varices.
Like dealing with varices.
Okay, so you're very right about that. We deal with a lot of cirrhotic patients. I think I presented something about bariatric surgery and cirrhotics a couple of days ago. Hepatology is our friend. They optimize the patient, and we really don't do anything if we see active or varices, esophageal varices that are ready to bleed endoscopically. For this patient, we had to bite the bullet. I mean, I had drains in there, 2 stents in there, and hepatology gave us the go for this. And I did not see big finger-like varices that I see in the other ones. So we bit the bullet.
We have been basically told in our literature that any intraoperative surgery for liver patient is very dangerous. But there is some data coming that is not as bad as we think. What is your experience about doing gallbladder surgery or any kind of intraoperative surgery in people with advanced liver disease?
My practice has evolved into bile ducts and pancreas, but one of the world's most famous liver surgical oncologists are sitting right next to me here.
So I just think that, so there's ways to evaluate objectively the extent of liver disease, and I think it just involves counseling the patient accordingly. I mean, if you're dealing with a child PUC patient, the mortality could be upwards of 50%, and the patient just needs to be aware of that. The other things that I would say for surgical considerations are, it depends what's driving the score. So there are things that are, worse for abdominal surgery, like ascites, for example, or portal hypertension and downstream sequelae of that as well. In general, platelets less than 100 tend to be a relative contraindication for doing surgery on those patients. And somebody who's preserved and compensated, even if their liver morphology is cirrhotic, that's usually not a problem. But I will say also, in my experience in operating on cirrhotics, especially advanced cirrhotics, is that the problems begin in the subacute term. So it's usually kind of days 3 to 5, things start falling apart. And so we do also rely heavily on our hepatology colleagues being involved in those cases. But it's of no benefit to anybody if you end up with a mortality. You've not helped anybody. So, we have to be very careful on who we take to the operating room and what the indications are. And there are a lot of ways to bypass the need for cholecystectomy, for example, with transpapillary stents or axios cholecystoduodenostomies and jejunostomies that we do as well. I think it's just a complicated multidisciplinary discussion. It varies from patient to patient. It depends. It depends. Every patient's a little bit different, as I mentioned, and I think it's what's driving the cirrhosis and the scores.
After a laparoscopy-assisted ERCP, would you advocate placing a PIC tube at the trocar site just in case the gastroenterologist needs to go back after?
If we think the gastroenterologist will need to go back, here's what we do. I still close up the patient. In one case, we did an on-table edge, or the patient comes back again and she gets an edge or he gets an edge, and then the GI people do that. Patients would hate a PEG tube to go in for a bile duct stone.
Because you have to dilate that tract. It's a process. So we have a discussion with our interventional gastroenterologist in terms of, do we think this is a one-time go? And if it is, then I think a transgastric ERCP is a great option. But if we are thinking that this is going to take several trips, that does make edge procedure more appealing. I've placed PEGs before, which gets dilated and then can allow for access, but it's not pleasant. And then you're dealing with the access issues, and then had a patient who ended up with a fistula that needed to be closed, not the end of the world. But I think if you're thinking that we're going to need a lot of trips, an edge procedure may make more sense.
Because there is always the issue of post-sphincterotomy bleed also. If you do laparoscopy assisted and you close and then the patient bleeds 2 days later.
Well, we can always go back and give more access, but that's another thing. If at the end of the procedure anyone's worried, then you can always either convert them to an edge if you are really worried, or know that you can come back.
Okay, thank you.
We're intentionally running a little bit over. There's no kind of anyone waiting for this room right now, but any other questions or comments or? Go ahead.
I have noticed that when surgeons decide to remove the stone, maybe the first speaker might answer the question. If the stone is too big, and it was mentioned that you can push it down to the intact papilla, does it have any risk for pancreatitis when we do this?
Yeah. So certainly that does increase your risk. So that obviously that's not your first go-to movement. Certainly that you can then dilate as well, but again, if you are good and pull it all the way out first, that's ideal.
Yeah, you can dilate the ampulla. You can also get pancreatitis from dilating the ampulla. So no good deed goes unpunished.
And in the case of the impacted stone, obviously, hepatojejunostomy and things like that, and what you do with the impacted stone is another kind of discussion, but also choledochoduodenostomy and leaving behind stones, kind of, sump syndrome and cholangitis and other problems. Yeah. All right. Well, thank you everyone for a great session, especially the speakers for all the hard work and putting together your slides. Greatly appreciated. Thank you.